And while you are coming up, I want to tell you, Mircea and Victor, that the reach is amazing. We are getting questions even from outside the audience, from the live feeds. So already we have a famous surgeon asking a question, Conrad Ballister from Phoenix in the United States. Conrad's question is for you, Mark, as we assemble. His question is, how do you define a recurrence after diastasis repair? And the follow-up question is, how do you follow or how do you survey those patients to follow them and determine if they're having a complication and/or recurrence?
Thanks, David. So first, how do you follow them up? I must look into my own soul. I don't do it systematically. So I agree with you. We should do it in a systematic way, as I just highlighted, as Bernd and Manuel highlighted. So we should do it in a systematic way according to a registry. So I don't do it. If they come back with a complaint, most of the time they're unhappy about the cosmesis. Most of the time they're unhappy about the cosmesis. So in those cases, I think you cannot get away without doing a cross-sectional imaging. I think you should do a CT scan, even if it was only to show to the patient that there is no residual diastasis. And again, I want to stress the fact that I said in the beginning, many patients come with a general laxity. And they think that the surgeon, they will take care of all the intra-abdominal fat, the lateral laxity, and the diastasis. So this is, I think, the very dangerous and tricky patient, because those ladies, they will definitely not be happy. So I think you should have a written informed consent. You should discuss with them the different options that you as a surgeon, you can treat the midline and maybe with your plastic surgeon do some plications laterally if needed. But I think that's the tricky group, and those you should follow them up, to answer your question, with some CT scanning, maybe with some biodex. We are now doing a select group of patients where we do biodex measuring, so isokinetic measurements of objective evaluation of the forces they have in their abdominal wall. So maybe, but this is just in research setting, maybe this will help in the future. But again, for clinical follow-up and routine follow-up, I think a CT scan should be done if they're unhappy. I don't know what Bernd or Manuel think.
Yeah, I agree with you, Mark. I agree also with Bernd that two types of patients, the adult men with a big belly and so on. For me, this is not a candidate for repair the rectus diastasis.
I agree.
Only the hernia. And the other side is a young woman after delivery or two deliveries and with rectus diastasis or in fact, an abdominal core problem. And I try to work together with a plastic surgeon because sometimes we need not only to duplicate or the linea alba, also to duplicate, to do the so-called, I think, abdominal contouring, you know, or add an abdominoplasty or so on. So in these cases, I try to control the patient and to treat the patient together with a plastic surgeon. And above all, the beginning of the operation is in the facilities, doing the shared decision making, explaining a lot the problems, the complications, the high incidence of recurrences, and so on. I think that this the key. The key is the counseling before the operation.
We should not feel guilty to offer these patients surgery because I'm getting more and more involved in this field. I see more and more patients coming, and with every patient I learn more about what's happening before they see us. And there's an uncountable number of physiotherapists, and I think they're doubling every month, that's my feeling, who come up with certain therapies named after a trainer or something, and they keep the women like years in their clinics and creating a chronic feeling of guilt in these kind of women. And just last week I saw a woman, she tried for 4 years. She's a lawyer, by the way, and she was very sporty. She has given birth to 3 children. Her tummy is destructed, okay? She has a diastasis of 7 centimeters. And the physiotherapist tell her she just has to train more and more and more and more. And she came with tapes, you know, these physio tapes crossed over across her tummy. And she was showing me videos of exercises she was asked to do. This is ridiculous, and that makes me angry because, you know, that's not evidence-based at all. And we really should not feel guilty for offering them an opportunity to get rid of the problems. And after surgery, most of these patients will feel completely different and back to the normal life.
I totally agree. I totally agree with your opinion here. I think we must learn that these postpartum floppy tummies are a real problem, and a problem what get medical solution, not only cosmetic.
And it's partly because they don't know. They don't know the literature. I know only a few physiotherapists who really read surgical or scientific literature. And the literature strongly suggests that physiotherapy after giving birth is not preventing diastasis. And it's for sure in the bigger diastasis not helping at all. We know that although the studies are not, you know, randomized, I agree, but the results are quite clear. And this
is what Mark already said. We all know about the Tupler technique and all this stuff what you can see on YouTube. This is just to make money, I think.
And the oldest patient I operated was 75 because she was told by her family doctor for 40 years, there's nothing we can do about it. And then we operated. It was not a massive improvement, but functionally it was much better because she was a little bit, you know, bigger then. But again, we should focus a little bit more on that. And I think it's a good thing that we have the registry now and we have good data, I think, in maybe 3 or 4 years. That's an excellent achievement. One question, Bernd, for the diastasis. If you do an umbilical hernia repair with a mesh, I agree. If, you know, a larger man with a little bit obese, do you try to cover the whole diastasis with the mesh? Because I come across these patients that come back in 2 years with a new hernia on top of the mesh.
In a young woman, yes. In a man, no. Only the hernia.
Yeah, but
because
they will
for
come
me,
back
it's
to-
interesting.
I cover the mesh from the xiphoid down, down, not to the symphysis, but
The gastric.
2 or 3 centimeters down of the umbilicus, or more,
Yes.
maybe 4.
But do you extend your mesh support for the diastasis, although you just have a small umbilical hernia,
For a man.
up to the xiphoid? Do you do that?
For a man.
For men?
For a man,
Good.
no.
Okay.
I don't do. I explained them. So everything I said was, of course, for females, postpartum. But in a man with an umbilical hernia and a classical rectus diastasis because of his age and a little bit overweight, I informed them, but I will not extend the mesh. I will use a preperitoneal mesh, but I will not put it further than classical for the umbilical hernia personally.
How many patients come back with a new hernia?
I haven't seen any in the last 25 years, so they probably come to another place. No, really. But I think information is very important.
But again, I think, Henry, we need some type of regulations because physiotherapy is okay, but sometimes appears in my facilities people asking me for a surgery because they believe that, for example, urinary incontinence improves with the rectus diastasis surgery. So, and I am not sure if it is in this way, but we need some type of regulation about the information that patients receive.
Franz, you have a question?
One statement, one question. I totally agree what you said. But to be true, the whole problem is maybe a matter of expectations. And we have to accept that we cannot fulfill all the patients' expectations. This is the first, maybe this is the first answer on the whole problem. One more question to Bernd. What do you think about perfusion of the umbilicus if you perform a sublay repair, reef stopper, and abdominoplasty? This is
Okay. This is I perform these operations together with the plastic surgeon. The plastic surgeon is a person who wants to save the umbilicus. I would cut it away, but at least we have done in the last year we have done 10, and we did not lost one umbilicus, none. So So I must say, the plastic surgeon might be right. It's possible to do it like this. And I put it more down because I resect the linea alba completely. The trapeze will be resected. It's going down. It's a little bit like ELAR without a second mesh. And then I put the sublay mesh and I close the midline again with the rectus muscle in the midline again.
What I think, we're going to take one more question from Jan, but what I think you can see in the audience is that we are now talking about a whole different thing that we do not understand yet, that is abdominal core health related. But the one thing you must understand is this is far, far more than the width of the linea alba, okay? It has much more to do than just measuring the width of a linea alba. So, Franz, you had a question, then Jan, you have a question, and then we'll finish up.
May I have one
Please,
more question
please.
concerning the perfusion of the umbilicus? From somewhere, the umbilicus has to get its blood. If you cut the posterior axis via the falciform ligament, it's gone. If you cut around the umbilicus, you cut all the vessels around, and there's no perfusion from a side.
Maybe you got me wrong. We don't cut it from the ground. We just cut it around, and we leave it to the peritoneum.
Yeah. Well, I'd like to confirm what Henry said before. There are papers, solid papers, Olsen from Sweden, 3 years follow-up after placations, Carrara, 110 cases with quite clear results. The urinary insufficiency improves in, not most, but in many cases. The back pain, which is the biggest problem of these young ladies, postpartum disappears. It takes at least 6 to 12 months because you have to rebuild the muscular strength. And I definitely agree with Henry, what you said, because while I studied about 11 years ago, my first presentation about this postpartum insufficiency was in Cologne in 2011.
Can I?
Yes, please, we'll have you finish up, Manuel.
I deeply respect your opinion, Jan, because you are my friend, but I disagree, totally disagree. The information in the literature, the level of the evidence is very low. But
So
we need to improve the quality of the evidence with better studies, yeah.
We're going to have the rest of this discussion, which will go all night, over drinks at the welcome cocktail reception. And thank you very much for all your attention today, and excellent, excellent sessions today.